Hello, everyone. Um, it's a great pleasure to be here for the next 45-50 minutes. And during this webinar, we will discuss, I think, very interesting topics. So before I start, of course, I would like first to thank Noble BioCare for the invitation. It's a great pleasure to be here during this less happy period of our lives, but at the same time sharing knowledge and sharing experience with the colleagues. And of course, it's a great pleasure. Thank you to the participants. Thank you to Noble BioCare for the invitation. And we will go through the presentation. Before I start, I have to make some general disclaimer. Of course, there will be probably some products shown here that are not available yet in all markets. Okay, and there will be a question and answer session in the end that you can write down your questions, and I will try to answer them in the end of my presentation. So today we are going to discuss and talk a little bit about the digital workflow, mostly for the surgical approach of the total edentulous. So I'm in Lisbon, Portugal. I work in the Malo Clinic for almost 16 years now. I joined 2004. I'm an oral surgeon, and we have a beautiful city. Unfortunately, for now, it's quite empty, like everywhere else, every touristic place in the world. But everybody hopes to this situation to change as quick as possible. So I joined Paulo Malo team in 2004. He has been my mentor, and is the pioneer of the all-on-4 concept. So it has been a great pleasure to work on this team for so long, and that's it. Starting and talking a little bit about this morning topic, of course, when we talk about the total edentulous patients, we know that there has been several revolutions with the times. In the 70s, we used to use superiosteal implants to fix removable dentures or fixed teeth. And during the 80s, we were doing as many implants as possible. We wanted to fill every piece of bone with titanium, and we wanted to graft. But then there has been evolution, and in the 90s we realized that we needed as minimum as possible minimum number of implants to support a fixed bridge. Okay, so this is when the all-on-4 came up. Okay, first publication is from 2003, the first paper on the all-on-4, but this started in the 90s. And I would say in the 2000 up to 2010, we've been developing and taking big efforts to treat the atrophic maxilla. And specifically with the zygomatic implants, with the extramaxillar approach, we managed to skip the bone grafts we used to do in the past. And this was a big, major through during those times. Today we are in a different era. We are in a revolution, a digital revolution. It's not so much the way or the techniques we are using, but the way we are doing. We are using technology. We are using all the weapons we have to treat better our patients, treat faster with the minimum invasive procedure as much as possible. And so things have changed, okay? So in the past, we used to use big grafts. We wanted to, and we needed to go for big flaps. We would need time and lots of time to do these rehabilitations with a big morbidity. But of course, now we are in a different era. We want to go graftless. We want to go flapless with less time and less pain for our patients. So we want to treat our patients better, faster, and with much more comfortable. And for that, we are using the digital the digital and the digital workflows and the technology. What's the importance of this? What's the importance of this topic? We know that in the world, for example, the percentage of total edentulous in the population over 65 years old, it's quite considerable. Okay, and because population is living longer and longer, in fact, this topic is gaining more importance because these numbers are growing, and we know that we will have more edentulous patients to treat in the future. And so this is a potential market, and this is a potential for our teams, and to help these patients to have quality of life on biting and eating in the last years of their lives. Okay, so this is very important. And based on this, we have in the last years we have created a protocol. This is something that we are using for several years. We call this the Malo Clinic protocol. And with the Malo Clinic protocol, we want to achieve several goals. Okay, in our philosophy, when we treat a total edentulous patient, first we want to have high success rates, meaning that this is already published in the literature. We know we are talking about 93% cumulative survival rate for the implants in the mandible, 18 years follow-up, and 95% for the maxilla with 13 years follow-up. We published this last year. We want to avoid bone grafts through non-invasive procedure. Okay, so for the total edentulous patients, we don't graft. We want a short duration period treatment. And the philosophy is to deliver a fixed bridge to the patients in the surgery day, a provisional acrylic bridge, through a quite simple surgical and prosthetic protocol. So this today worldwide, and this is another reason all the other companies also today have a kind of all-on-4 system, is of course because this is a quite simple surgical and prosthetic protocol that has been pioneered by us here in Lisbon, and that now it's used worldwide by several colleagues around the world. So the philosophy is to allow the patients to have TC immediately. We have to think about maintenance, so we have to design the bridge in such a way this is cleanable. And of course, if we compare with the bone graft procedures and extensive treatments, this can represent a low cost for the patient. So my topic here today, I will go through diagnosis, surgical part, and final rehabilitation. Well, when we talk about the diagnosis is crucial for the success of the treatment, and we can say that, and I will highlight only 4 topics on this diagnosis: the type of rehabilitation, the type of prosthesis we can use, the transition zone, and the bone volume and the bone density. Okay. When we talk about the type of rehabilitations we can propose to a patient, summarizing, we can have, I would say, around 6 options. Or we go for a denture, or we go for an overdenture, or we go for parallel implants, or if you want to go fixed solution over implants, or we go for all-on-4 treatment. In the trophic maxillas, as I told you, in the past, we used to graft big bone grafts and big morbidity treatments that we don't use anymore because we are using the zygomas. But this is specific for the atrophic maxilla. And I would say the standard cases, of course, the option should be between the parallel implants or an all-on-4. The parallel implants, there's no doubt that they are the gold standard. But the reality is, of course, is that most of the time, especially in the maxilla, we don't have this amount of bone conditions, bone volume and density to perform 6 straight implants. And so that's how the all-on-4 came up as a solution to skip these problems when we have less bone available. When we talk about the prosthetic part, of course, here in our protocol, we call and we talk about the Malo Clinic bridge. So this is a 1-unit bridge with artificial and always with artificial gingiva and the teeth. So we have always a pink part. This is also mandatory on this concept. And with this, we are able to provide the best aesthetics we want, and this allows us to be predictable in all our treatments. Okay, we will discuss this in the end of the presentation again. And another important topic, of course, for diagnosis is the to diagnose and detect if we need or not to go through a bone reduction. Okay, so there are three factors mostly that can help us to define if we need to perform bone reduction: through the smile line, the prosthetic space, or the lip support. The prosthetic space, we know we need at least 15 millimeter of prosthetic space for this kind of maloclinic bridge. The lip support is also important, but the main issue is the smile line, because again, especially in the maxilla, we have to ask the patient in the beginning of the treatment, we have to take this picture with the patient smiling to check the smile line of the patient. And if the patient is a high smile line patient, is showing gum before the treatment, when he smiles, we have to know that we should perform bone reduction, and we have to remove, I would say, to reduce 2 to 3 millimeters of bone than what they show. This is very important for the success of the treatment, so that the transition zone between the natural and the artificial gingiva on the bridge, it's not visible when the patient smiles. Finally, I have to highlight the importance of the bone volume and the bone density, again, specifically in the maxilla. In the mandible, things are pretty much straightforward, but in the maxilla, we have to know that, of course, there are several ways of approaching the surgery in the maxilla. If we have full bone volume, we should go again with 6 straight implants. But of course, if we have a bigger resorption, if we have a bigger sinus pneumatization, then we rather prefer to tilt the implant, the distal implant. We start always by placing this distal implant and go for the all-on-4. And then we call this the all-on-4 standard. We can end up with the implants on the molar and canine, or in the second premolar and lateral position, or even in the first premolar and central. And this was something that we published already in 2011, this classification. And when we start to get into the atrophic maxilla, on those cases, of course, we have to go through extramaxilla fixation with the zygomatic implants. And we can use one standard implant and one zygoma. We call this the all-on-4 hybrid, or we might have to go with 2 zygomatic implants, and we call this the all-on-4 extramaxilla for the really atrophic cases. But independently of the bone resorption, we know that independently of the bone we have, the prosthetic part, the prosthetic solution remains the same. We have today the opportunity to give the same bridge, ergonomic, statics, and functional to all patients independently of the bone volume. Well, now we have to go through surgery, of course. After doing a good diagnosis, we go for the surgical part. So I don't need to spend so much time here. I think everybody knows what the all-on-4 concept is. We only place 4 implants for maxilla or mandible rehabilitation. We tilt the posterior implants up to 45 degrees to skip the nerve in the mandible and the sinus in the maxilla. We can fix and anchor our implants in the jaw or outside of the jaw if we go for zygomas. And every time needed, we use cantilever for the final bridges to deliver 12-unit bridge from first molar to first molar. And of course, we go through immediate function. Patient leaves the clinic with fixed teeth, and we always go for bone reduction every time needed, as we already discussed. What are the advantages? Here we are simplifying the totally dentureless patient's treatment. We want to avoid bone graft, because using autogenous bone allows us to immediately get better primary stability and go for immediate function. Besides, we have high success rate. This is more than scientifically validated today. And of course, with this kind of treatment, we allow the patients to immediately have teeth with a hygiene or a good hygiene maintenance capability, because we only have 4 implants, meaning that we have 3 pontics, and it's easier for the patient to keep hygiene. Well, coming to the, I would say, the topic of this this session, and when we talk about digital workflows, of course, today we have tools, we have softwares that allow us to go through our treatments, surgical treatments, in a pretty much more, I would say, accurate and precise way. Today we have the DTX Studio implant software. It's a very nice and intuitive software where we can, I would say, have several levels of utilization. Okay, so I can just use this software to preview or pre-plan virtually in the software my surgery. This is what I do every time I go for zygomatic implant placement. I create the 3D shape of my jaw. I plan on the computer, and then the next day I go freehand procedure. But I already went through the case. I know what's going to happen. I know the anatomy of the patient. Maybe I know the size of the implants I'm going to use, and things are pretty much more predictable and more easy for the surgeon point of view. Then you can also use the software to create surgical templates. This is called static guidance. And here we can go with the software to a partially guided workflow, meaning that we create or we order a surgical template that allows us just to use the pilot drill, the 2mm drill, to start the initial osteotomies, and then you go through the rest of the procedure by yourself. Or you can go fully guided procedure. This is something we are using since 2005. We have 15 years of experience with fully guided workflow. Also works pretty fine on the specific case indication, and this allows us to go through the surgery, prosthetics, and putting the abutments and the bridge in the same moment, because everything is predefined on the digital workflow. And finally, for 1 year and a half, we've been using navigation. So this is the new, I would say, revolution now that allows us to have another way of approaching these patients, this rehabilitation, with also very nice and interesting tools that we will discuss later on. So I will go and illustrate one by one these approaches so that you can understand. And starting with the non-guided approach, the freehand procedure, of course, I bring here a case, periodontal case from a patient that we treated more than 5 years ago that had chronic periodontitis with severe mobility, big bone loss. Patient was a little bit already not satisfied with the result from the periodontal surgeries, with a lot of sensitivity, teeth mobility, and so he wanted for and he came to us for another solution. Okay, and so we use the software to help us. The software allowed us here to transform DICOM files into 3D image, and also to diagnose the bone resorption we had on this periodontitis, and helped us to as well decide that we wanted to extract all these teeth and check that the enough bone volume we had was enough to perform a bimaxilla all-on-4. And this is what we have done. Well, this is the surgery day. So we started by extracting all teeth. We raised the flap. We clean all our infections in the sockets. We have to perform some bone reduction because on these cases, the bone anatomy is quite irregular. So we have to level everything, and we start our all-on-4 procedure. But here, because we have seen already our, I would say, our patient's anatomy on the software, this allows us to be more predictable and to have more notion where we were going during our osteotomies and implant placement. And of course, this is a great help for the final, I would say, outcome from the surgery. Then on the same day, we performed the same procedure in the lower jaw. We extracted the teeth, raised the flap, clean all the infections, and after that we level the bone, and after that we put the all-on-4 guide, and we start our implant osteotomies to rehabilitate the patient with the bimaxillary all-on-4. So this is the picture of the patient with the immediate bridges and the panoramic radiograph in the end of the treatment. And 4 months later, patient comes back for the final bridge procedure. And you can see here very nice, I would say, pink and healthy keratinized tissue around our implants, and with a very nice osseointegration as well. And this is already the final bridge, maloclinic ceramic bridge on top, acrylic bridge in the lower, and as you can see, with a very nice implant distribution in the occlusal views of this case. So this case, as I told you, was treated around 6 years ago. This is the final radiograph with the final bridge, and upper and lower ceramic on top, acrylic in the lower. But more important than the radiographs are the final outcomes and the way we can change these people's life. Okay, and this is amazing, the transformation we get from the before treatment with the provisional bridge in the center, and on the right side of the screen, the patient with the final bridge, showing that patient is really happy. And this is the big thing about our profession, about our job, that we are not just placing teeth, we can really, in fact, change these people's life. Then we can go a little bit more further with this I would say with this digital workflow. And for partially guided procedure, I want to present this case here, a very young patient. She had a very tough childhood, no economical resources, so she got her teeth extracted very soon, and she came to us with the denture that she had for a couple of months, but she wanted a fixed solution. And so, of course, we always start by, of course, make a photograph session. We take radiographs, we take CBCT. Today, of course, we are also doing the intraoral scanner, and we can see here that on this case, the patient has in the maxilla, that's the jaw we are going to restore. We had the typical anatomy for the all-on-4 with the sinus in the back, and we have irregular resorption, mostly on the left side, on the right side, the bigger resorption, and then the irregular crest on the patient. So when we go for the smile line picture of this lady, you can see that you cannot use a natural gingiva bridge here. Okay, we have to go through a bone reduction process, and we have to go through an all-on-4 concept rehabilitation. However, of course, we cannot go fully guided with these cases, so we went partially guided. And then what did we do? Using the double scan technique, we just put some Guttepesche markers on the denture, and we scan the patient with the denture on. Then we scan the denture alone, and we merge everything together in the software. And in the software, we were able to decide the best position for the implants, the best osteotomy position. And we decided to order and produce a pilot reel surgical template, okay, so that we are just using the 2mm drill with the guide, and then we will have to raise the flap and do the bone reduction because of the smile line of the patient. So let's see the surgery.
So on surgery day, we start to adapt and stabilize our surgical template with the 3 anchor pins. And we are going to use the guide to give and do our first 4 osteotomies. After this, as we know, we have to raise our flap. We have to do a bone reduction so that we don't have any transition zone visible between natural and artificial gingiva later on. And with a rounder or a burr, we level the maxilla. And the great thing about this technique is that you have the osteotomies, the first ones already marked that we use through the guide. And so now I just have to follow these osteotomies to place my implants. Of course, we have to still, this is a mix between guided and freehand, because we still have to feel the bone, decide for the drilling sequence. And here we have a noble parallel CC implant regular platform in the back, connected with 30-degree abutment. Moving to the front again, we just the bone density was quite good. We consider this as medium bone for the maxilla. We use a narrow implant, again parallel CC 375 by 11.5, and multi-unit abutment 1.5 millimeter. And in the left side, we just follow again these initial osteotomies that were performed with our pilot drill surgical template. We torque the anterior abutments 35 newtons, and we suture back, we do our impression, and what we are going to do here, we are going to use the denture directly in the mouse in, of course, direct method, and we will, with a rubber dam and with the titanium cylinders, we will pick up the 4 cylinders in the mouse, asking the lab to finalize, and in 1 hour, 1 hour and a half, patient is done with the provisional bridge.
Okay, so this is the setup we were using to film this surgery. We had Johan Langinius' team coming to Lisbon to help us, and here, as you can see, this is our post-op panoramic showing a very nice implant distribution that, in fact, was decided in the software, not in the operating room with the patient. Okay, so this allows us to get a high level of performance, higher precision, and even more, I would say, take advantage of the existing bone. So this is the post-op intraoral pictures just on the surgery day, and the patient comes back 10 days later for suture removal. And once again, another case that after 10 days, you can see already the changes, not only in the patient's mouth, but on the patient's, I would say, self-esteem and psychological behavior. The same way, after 4 months, we restart the treatment to do the final bridge procedure. And here we went through titanium acrylic bridge, the all-on-4, the Maloclinic acrylic bridge. And with the 3 years follow-up, I want to show you the periapical radiographs of this case, showing a very nice bone stabilization around these implants with a very nice biological response of these implants and to the function of the patient. Of course, the patients, they come for the aesthetics. They want to have nice teeth. They want to eat properly. They want to smile. They want to be happy. And this is, in fact, what we get after these treatments. And there are no better, I would say, marketing. There is no other, no better way of publicity by having these patients smiling all the time and showing your work every time they smile. So then I want to show you a fully guided workflow. As I told you, this is something we already have published, the all-on-4 with the Noble Guide. We've been doing this since 2005, and this says we have a specific workflow. So we have to select correctly the patient. We have to have a nice denture, a nice radiographic guide, and scan the patient and the denture properly, so that we bring this information to the software and we have all the surgery done virtually in the software. And this will allow us to produce a static guide surgical template that will allow us to place the implants properly in a flapless way, but with the advantage of having the prosthetics done, the provisional bridge ready before surgery. For this, we have here this patient. This is a patient that was using dentures for many years. She is around 60 plus, and she was really willing to have a fixed dentition. Again, we have here a big and pneumatized sinus. We have a considerable big resorption. So here we don't graft. We don't need to go in the maxilla to do any sinus lift procedure or bone augmentation. We just need to go through the all-on-4 procedure. In the lower jaw, we decided to extract the right side premolar, and we decided to keep the remaining teeth. These are the extraoral and intraoral pictures before treatment. The dentures. The denture here, on her case, didn't meet the necessary requirements, so we decided to do a new denture before we did the scans. And here, as you can see, this is the edentulous area we are going to restore. Once again, very important, we have to check for diagnosis reason the smile line of the patient. She's a low smile line, so there is no need of, we had the necessary prosthetic space, so we don't need to do and perform any bone reduction. So we don't need to do anything, so we can go directly with flapless implant placement with Noble Guide and all on 4. And as I told you already, we had to do a new denture that we use for the scanning and the preparation of all the case.
On the surgery day, everything is pre-planned. I know exactly what the type of implant I'm going to place. I know the angulation, I know the position, and this was done previously in the DTX Studio implant software. So in order to have an exact, I would say, position of our implants in the mouse, we have to be sure that our template is well connected and well adapted when we place the anchor pins in the beginning. This is crucial. Besides that, after that, we just have to follow the sleeves we have on the template, and we have to be concerned about the drilling sequence we are going to use, because don't forget, we want to go immediate function. And for that, we need the necessary primary stability. So the protocol is pretty straightforward. We just have to follow the guide, follow the drilling guides. And here we plan the all-on-4 with the Noble Parallel CC, 4.3 diameter by 15 millimeter implants. All the implants were the same length. And we found a very nice maxilla, meaning that we were able to place our implants in the right place with a good stability so that after surgery we can load them. And you can see here, there is no bleeding, there is no incision, there is no flap. This is a minimum invasive procedure, and in less than 1 hour, we are able to deliver the teeth to the patient. Here we are connecting the 30-degree multi-unit abutments in the back. We connect the straight multi-unit abutments in the front, and we have this jig to check the abutment position. So after this, we also have the provisional bridge pre-made, and so we just have to put it in and check our occlusion and ask the patient, of course, to go home because the surgery is over.
Well, here you can see the final panoramic radiograph. As I told you, we have published this 2017, our 7-year clinical and 5-year radiographic outcomes with the all-on-4 and Noble Guide, showing here again very nice precision and amazing outcome in terms of post-operative comfort, because it's amazing the way these patients recover from the surgery. Here you can see periapical radiographs showing the precision, the implant placement and position just after surgery. And on the surgery day, patient leaves the clinic. We did the same. We did also some implants in the lower jaw. We placed what we call the half all-on-4 concept for partial cases on the right side, and with a provisional bridge. And after 10 days, patient comes back, and as you can see here, we can see the difference on the healing process from the upper jaw, where we have no flap, no incision. We went 100% flapless, compared with the lower side, right side, where we had still the gum, the gingiva healing. It's completely different. After 4 months, we delivered the final bridge. Here we went again for titanium acrylic solution, and here, as you can see, we came up on the molar area with the implant, distal implant position in the maxilla, showing that we have no cantilever. the best implant distribution and the very nice final outcome here already with a 3-year follow-up radiograph showing I would say the long-term behavior of this type of rehabilitation. You can see here the periapical radiographs with 3 years follow-up as well. And again, we can see good bone stability and good bone behavior around these implants in function for more than 3 years. And once again, the big thing about these treatments is this life transformation. And there is no doubt that these patients, after these treatments, they look at least 10 years younger, because they, of course, after the teeth comes the lipstick, then comes the hairdresser, then comes the necklace, the earrings, and sometimes these patients, of course, they feel so good, they change the job, they change the car or the apartment, even sometimes they change the husband or the wives. So it's really a life-changing treatment, starting with the teeth. Finally, of course, I wanted to show you what we are doing now, most recently concerning navigation surgery. And here I want to present you this patient. This is a failing dentition case, a patient with several teeth, but as you can see here on the radiograph, these are hopeless teeth with periodontal problems, decays, and of course, a lack of some infections around some roots. And so here the decision was to extract these teeth and immediately place implants through the all-on-4 concept, again, as we don't have any posterior bone for implants in the back, in the maxilla or the mandible. So the patient is gummy smile patient. We have over eruption on the upper incisors, and as you can see here, we have to perform bone reduction. We have to extract these teeth. Everything has to be reconstructed. These were the dentures the patient was using in the beginning, and this is our situation now that we have to work with from the start. So on this type of situations today, what we do, we just we go for CBCT here. Because we decided to go with navigation, we had to use these clips. And these clips, these are rubber clips that we use on this case specifically. We use the teeth we had to keep these teeth as holding these clips, because they will allow us the system to work during the surgery. So what we do, we put these clips on, we scan the patient, intraoral scanner. We do a CBCT of these patients with a clip in the mouth. And then the second thing we do is intraoral scanner. Okay, and with the iOS, we have all the information together with the CBCT in our initial photographs to restore and do the rest of the treatment.
In the DTX Studio Implant software, we will have all the information we need. In one side, we will have the CBCT information, and on the other side, we'll have the intraoral scanner information as well, that we merge with the Smart Fusion function, and this will allow us to do our planning in the most precise way. So here we knew we had to do some bone reduction, upper and lower, and so we calculate this and we plan our implants, Noble Parallel CC TI Ultra implants, in such a way that we have a perfect planning all on 4B maxilla. On the surgery, we start by holding the clip in the same position. The clip is holding a receptor, and this is a kind of GPS system where we have two stereo cameras that are filming and receiving information from these two receptors that are in the contraangle and in the attached to the clip. Besides that, in the clip, we will have three metal balls, the fiducials, that allow us to match the planning information from the software and the patient's jaw. And so this is a live navigation, meaning that in real time, I know exactly where is my patient's mouth and where is the planning and where I should drill my implants. So the surgeon has to look to the target. We are not looking at the patient's mouth. We are looking at the screen, and we are trying to fit and go through the point of the target, the center of the target, which is exactly the position we decided in the computer to go through with our osteotomy and the implant. And so one by one, we go and place our implants through this software and through this target in such a way that we are as precise as possible with our planning. So this is not, we don't have a physical plastic guide like we do in with the guided surgery. We have a GPS that helps us and allow us to do live navigation surgery. We perform our all-on-4 in the maxilla. We got all our implants into a good primary stability. We remove our clip. We do the final extractions. We raise the flap a little bit more. We do the bone reduction like we planned. We place our abutments. We suture back, place our impression copings, and do our impression. In the mandible, we do similar approach. We use the left side lower premolars to hold the clip, and this allows the system to work. And at the same way, we follow now the lower all-on-4 planning we did before, and we just have to again look to the screen, follow the target, and be as precise as possible so that our implants get in the right position. Once again, we have to work with the drilling sequence. We want to have a good primary stability. We have a system. We have a second ring around the target that is yellow, giving us the depth of the implant. Turns red when we overpass this measurement. And so this is real-time navigation that we can even adjust and change the planning during the procedure. And this is a great advantage compared with the static guidance. So at this point, we are placing the last implant, our last Noble Pearl LCC implant. We remove the clip, we extract the teeth, we raise the flap, we reduce the bone, place our abutments, and suture back and do our impression. Send everything to the lab, and a couple of hours later, we have our provisional bridge ready for delivery. At this point, we typically deliver a 10-unit provisional bridge that the patient will use for 4 months before we change for the final bridge.
Well, here we can see the provisional bridges. Today with this navigation, specifically for the total dentals workflow, we know that there are some news. There is some algorithm, a better algorithm now that will allow us to, I would say, to skip the CBCT part with the clips. This is called the X-mark protocol, and we know that today, maybe the near future, we'll be doing these procedures just by selecting a normal CBCT without any difference. And what we have to do is to tell in the software, mark a part of the tooth, and in the patient's mouth during the surgery or before the surgery starts, to mark the same point. The system will match automatically the planning with the head position of the patient. So we are developing this. This is a system that is improving, and there is no doubt that this is a great tool with a great potential for the better treatment of our patients with the navigation system. Here we have our patient satisfied. This is just a provisional bridge. Of course, we are doing now the final bridge on this patient, and I hope when things returns to the normality to show this case with the final bridge as soon as possible. Here we have the post-op panoramic radiograph, as you can see. Again, very nice implant distribution. And we have a post-op CBCT also showing the position where we have placed our implants following the planning and the navigation, the XNav machine, allowing us to do our best for our patients. So to finalize, of course, we have to talk about the final rehabilitation. And the Malo Clinic Bridge, as I was telling you, is always a one-piece bridge concept that we use for, again, more than 15 years in our clinics. We can use three materials: full acrylic, metal acrylic, or metal ceramic. We will always use false gingiva, as I told you, pink gingiva. We can use cantilevers every time needed to restore 12-unit bridge, and we will always go through immediate function on these patients and perform bone reduction for prosthetic space reasons every time needed. What are the advantages of this type of concept bridge? We have always high statics. It's predictable for all cases. We get high mechanical resistance because we have a metal framework. We have still a high hygiene maintenance capability. We have a very fast repair system, and the cost-wise, so not expensive. I will explain you how. And of course, low cost for the patient if we keep the full acrylic bridge on the patient, which is rare. So talking a little bit about the all acrylic bridge, this is the Maloclinic acrylic bridge. This bridge, we have a titanium bar that is milled, and then on top you can use whatever you want. You can use stock teeth. You can design your teeth on the digital workflow and have them milled as well in the material you want. So, but typically this is a bridge that is very easy to repair, and that today in our labs we just with this technology instruments we just need to scan a wax up or even a provisional bridge in acrylic. We just have to digitize it, to scan it, and then on the DTX Studio Lab software, the software for the lab technicians, we can design 100% the bar and have it milled and have it in the office in a couple of days to finalize and do the final restoration with acrylic. So in our patients, we use or acrylic against acrylic, maxilla and mandible, or ceramic on top against acrylic in the lower. This has to do with the patient's decision in terms of economics. And then the Maloclinic ceramic bridge, which is a concept bridge that we have a pretty much a little bit more complex titanium framework, but the principles are the same. These are milled titanium structures. There is no welding. And then on top of this, we will cement 12 individual ceramic crowns that will try to mimetize and reproduce the natural dentition. This is the top quality bridge we have. And the biggest also advantage is the fact that if I need to repair something, if I need to do any maintenance, I just need to, of course, replace one crown and not need to redo all the work. This is a picture from the framework we've been using again for more than 15 years. We published this in 2012, this paper about this bridge, and here you can see the results, the final result we can get, the high statics, function, and similarity with the natural dentition. Today we have the chances to do this again on the DTX Studio Lab in the full digital workflow. So we just need to scan again a wax up or a provisional acrylic bridge, and in the software we are able to design and individualize the titanium framework that we will order and get it in our lab, and also we can individualize and design and have these individual crowns, ceramic crowns, milled with the shape you want. And then these are lithium disilicate crowns that we just need to characterize and cement on top of the framework and finalize with the pink acrylic gingiva. Okay, just to finalize my presentation. So I want just to finalize with the systematic review. Today we know this concept is more than I would say scientifically proven. We have this systematic review from Patzelt from 2014, where he selected 13 articles, almost 5,000 implants followed up with 74 failures, meaning that we have a survival rate of 99% with the 99 for the implants, with 99.9% survival rate for the prosthetics. Okay, so for a conclusion, I would say slide. I would just say that this type of rehabilitation, again, everything I've been showing to you this morning, it can be done with not with the all-on-4, but any type of rehabilitation. If you go for 6 implants or whatever. Here today we are talking about options, about surgical way of achieving. So, but we know specifically on the all-on-4 that this system is predictable, minimum invasive. We have immediate results with a high success rate and very low percentage of complication. And if you can use technology, if you can use the digital tools we have today, like we use everywhere else in our cell phones, in our cars, in our televisions, in our life in general. Today we have these tools with intraoral scanners and with the CBCTs and softwares. We are able to optimize our patients' treatments and treat our patients better. So thank you a lot for your attention. I leave here my email and my social media data, so that we are in contact in case you have any further question that we cannot answer during this webinar. We will have now some, let me check some questions here, and let me wait here. We have some questions. We will for sure will not have time to go through all of them. I'm looking for them all the way down. So first question, can we have fully guided zygomatic implant placement? Well, this is something that it's not advisable or not possible. Okay, so meaning that what happens when we go guided surgery, we have always a 0.something millimeter discrepancy for the conventional implants. And we know for the zygomatic implants, this lack of, I would say, this lack of or this little mismatch with what we plan and what we get in the surgical on the surgical moment, because these are soft tissue plastic guides that are supported on the soft tissues. So there is always some deviation, and so some 0.something millimeter in a small implant can mean more deviation in the zygomatic implant. So it's not really advisable to go with the fully guided on the zygomatic implants. Another question, why did you use all-on-4 parallel implants? Why did you use all-on-4, not parallel implants, in the case of full extraction in the mandible and the maxilla? Why did you use all-on-4, not parallel implants? Well, today, I would say, we can use in a very, I would say, predictable way, 2 types of implants. We are very experienced with the Noble Speedy implant with external X, and we use, I would say, the Noble Parallel CC implant as well. So these are implants with a very nice macro design to engage in the bone and get a very nice primary stability. Okay, the pointed apex allow us to go through the bicortical, and in this case on the cortical of the nose, and this allows in soft bone cases to get pretty much more primary stability. Third question, how much we should do cantilever in such cases? Well, this is it. If you are using on the provisional bridge, we don't go for cantilevers on the provisional bridge. Okay, during osseointegration, we don't use cantilevers. But for the final bridges, we want to deliver always 12-unit bridge solution, 12-unit bridge. So for that, independently where anatomically your implants go out, we have the experience that if you are using a milled framework in your bridge, you can have up to 2 teeth cantilever. So if your distal implant is coming out on the, I would say, first premolar, you can still go the second premolar and molar in cantilever if you have a sufficient prosthetic space in height and you have a milled titanium framework that will allow you to have this cantilever. Of course, this is something that doesn't work with, I would say, monolithic zirconia, for example, solution bridges. This you cannot use for this type of cases is a disadvantage because the zirconia doesn't allow such a big cantilever. But if you are using this system, titanium acrylic, titanium ceramic, you can go up to 2 teeth cantilever in the mandible or in the maxilla. Another question, is it possible to do bone support surgical guided by using DTX Studio? Well, I believe bone supported, I believe you cannot use it. So I just showed to you the potentials and the what you can do with this DTX Studio implant software. Okay, so this means that or you go soft tissue supported surgical templates, or then if you go navigation, then you can go through the same way. It's a dynamic guidance with the navigation against the static guidance with the surgical template. Okay, so on this system we are not using bone guided surgical templates. Okay, another question: can we place zygomatic implants using implant navigation? Well, yes, you can. This is something. This is something that we have already tried. This is something, honestly, that Noble Biocare doesn't want us to talk too much about, because there is a learning curve for navigation, like every other techniques, and so you should go or even go for this type of concept only if you, of course, are already very experienced with the single and partial cases with navigation, then full arch standard procedure, and finally zygomatics. If you ask me if it's possible, the question is yes, you can use navigation with zygoma. This is something that this will come with time, but for now, the recommendation is, of course, you use this for a standard full arch procedure and for single and partial. Another question here, how, maybe probably is the last question, and let's see, how do you manage the occlusion? What about full zirconia for final? Okay, that's what I say. The occlusion is like this. When we go through the provisional bridge, we leave the occlusion mostly on the acrylic bridges from canine to canine. We want to have no contacts or very light contacts in the premolar area on the provisional bridge. In the final bridge, occlusion scheme is similar with the natural dentition scheme, meaning that, of course, we try to mimic the natural dentition, more contacts in the back, lighter contacts in the front. Of course, if you have a big cantilever, this has to be a little bit light occlusion. And about zirconia, monolithic solutions, it's possible, of course, but again, for the all-on-4 concept, we are using, as I was saying, sometimes and big majority of times, cantilevers, and these cantilevers lots of times also doesn't allow for the zirconia to work. So I would say that in a regular basis, zirconia is not our first choice due to this reason. Okay, we still have here some questions, but I will answer them later on with you by email. Okay, we are running out of time, and I just wanted to take these last seconds to thank you once more for your attention. It was a great pleasure, and see you around. Thanks a lot. Stay safe and take care. See you soon.